Hello, this is Dr. Ayub. Today I like to show you a couple of sonographic images of acute pathology. I made this PowerPoint presentation by aggregating the couple of acute pathological condition that mostly happen in human body, mostly in the abdomen and the pelvic area. So I hope you will get a clean and clear informations and idea about how to describe the acute pathology of the organs. So before going to details, I just want to make sure that you understand the acuteness. What is acute and what is chronic? So today I will discuss with the acute. Acute pathology means abnormal situations just happen, suddenly happens. And you can say first time happens. So then what happened? An infection. An infection, mostly the infection, we call it acute infection. There is some situation called chronic obstruction, acute obstruction, chronic infection. But today I will discuss about the acute pathology, sonographic description. Sonographically, how are you going to evaluate an organ that has an acute infection? Understand that acute infection causes 5 things. We call it color, dolor, rubor, tumor, and functiolesa. So these 5 things I usually want to remind to our students and all sonographers, all people in the medical science, that it has a meaning. Color, dolor, rubor, tumor is a very sequenceful wording, and color means the heat production. We call it calorie. Calorie is the heat production calorie. So the word taken from color. Then we call dolor. Dolor means pain. It is in Spanish language. Dolor means pain. And rubor. Rubor means redness, congestion. So in acute condition, so in acute infection, there is congestion of the organ because of the hypervascularity that causes congestion. And because of this congestion, you should understand the organ gets more juicy. Juicy means edematous because of the too much watery materials inside the organs. And because of this organ congestion, the organ gets bigger, enlarged. That's why we call it tumor. Okay, so after rubor, this is tumor. The organ gets enlarged. Then, because of the infection, so the normal physiological function is deteriorated. That's why we call it functiolesa, the less normal function. Then how do I know that? I will know because I will do some lab work or blood work. Then I will see the normal physiological values of the test are abnormal. So in that way, we will understand the patient will complain in acute infection that I have fever. That is color. I have fever. The fever has a lot of characteristics. Some fever is coming, the high rise of temperature followed by no temperature, and sometimes the infection, the fever is continuously low grade fever. Okay, intermittent fever. Okay, so this type of fever is common in infection. So then patient will complain about the pain. Because why there is a pain? Because due to infection, there are some chemical, infectious chemical. That chemical is released in that area, and that causes involvement of the nerves, and that infectious materials also get absorbed in the blood, and in the blood there are some, it goes to receptor cells. There are some organ that has a receptor cells, those will be excited with that infectious chemicals like interleukin, the leukin, and so many other chemicals that will excite, that will activate, that will invite lot of inflammatory cells. So they will come into that infectious area, and then all those things will be aggravated. And if the fighter force or immune cells in our body, defense cells in our body are winner, then infection gets subsided and naturally. Otherwise they have to take especially antibiotic, so that antibiotic can kill the germs. So in that way, so the symptoms will be reduced and patient will feel free. So fever, pain, and pain has a characteristics. Pain will be couple of nature: throbbing pain, then colicky pain, sharp pain, stabbing pain, staggering pain, dull pain. So these are the nature of the pain, depends on the what type of infection is it. And example, if there is a abscess, the abscess will have throbbing pain, feel like the pulses at their heart is there, you can feel the throbbing pain. If there's a pain in the gallbladder, pain in the common bile duct, so you will see the spasmodic pain or colicky pain. Pain comes and pain goes, like a labor pain. Okay, so sharp pain. So it is example, the something is rupturing, so rupture ectopic pregnancy, rupture cyst in the ovary, so that will give the sharp pain. And the dull pain, that is another pain. All the time there is a pain. Okay, and intestinal obstruction also, that gives you colicky pain, spasmodic pain. So, and you will understand the hepatitis, liver infection, that will, if the liver is enlarged, so liver has its own capsule, Gleason's capsule, get stressed and you feel pain, and that pain is all the time on the right side. And sharp pain, certain pain, some pains are radiating pains. Example, gallbladder pain is radiated to the right shoulder, chronic gallbladder infection, acute infection, and it goes into the through to the back, and Murphy's sign is positive. So pancreatitis also has a pain, that pain is in the epigastric region and it goes directly through to the back. Okay, kidney pain, it starts in the lumbar region, then it goes into the pelvic cavity, pelvic area. This is called a radiating pain. And the appendicitis pain, so that has also radiating pain. It starts in and around the umbilicus first, then 6 hours later, 6 to 8 hours later, it goes into the McBurney's point, which is in the right iliac fossa. Okay, so these are couple of things I am just giving you, and you will feel there's a bump, means it's a tumor because of the organ gets enlarged. So in acute infection, you will see the liver gets enlarged, spleen gets enlarged, appendix get enlarged, then gallbladder wall gets thicker. Okay, so tonsillitis, tonsil gets enlarged, ophoritis, orchitis. So many organs that has acute infection, usually the organ gets enlarged and congested, reddish, okay, due to hypervascularity. So these are the way the patient will complain for acute infection. So that I feel fever, I have pain, then I feel there's a bump, I can feel it, its organ is enlarged, okay, and organ is congested. So some area, if you see there is an abscess happening in your face anywhere, then you will see there is an area which is bump, you can feel it, and it's pain, and the local temperature is hot, and it is congested. Okay, so that's the way you will see the acute infection. So now I like to give you sonographic images that will help you how to describe the acute infection. Okay, so now this image is acute hepatitis. In this acute hepatitis, you will see this side there is liver here, liver, and this is another liver, and this is liver and the kidney. Okay, just look here, this is a very good image that in acute hepatitis the liver gets more darker, it is more hypoechoic than its usual. So then what going to happen, if it is more darker, then you will see the portal veins in the territory of the liver all gets brighter, just like a brighter stars in the sky in a dark night. So if you see this type of feature in the liver, and the patient has all those symptoms, I have fever, I have jaundice, and I have pain in the right side of my stomach, and urine is yellowish, and the liver function tests are abnormal, so then you can diagnose with this view that it looks like it is acute hepatitis. Okay, so now look, this is a normal hepatitis. Just understand that this is normal liver, and it has no bright stars in here. So here you see a little, but liver is darker, more darker, and some echogenicities of the portal veins, you see it is little more, but this is the best one. You can see this is acute hepatitis. Okay, so now let's go to the next one. Acute cholecystitis. What is acute cholecystitis? Acute cholecystitis means infection to the gallbladder walls, and 95% to 98% cases you will see the acute infection to the gallbladder is due to the stones, with the presence of stones in the gallbladder, and most of the time these stones will obstruct the gallbladder neck or common bile duct, and as a result there will be stagnation of the bile in the gallbladder. Sometimes you will see the stone is causing irritation to the gallbladder wall, and the gallbladder has erosion, and gallbladder has bleeding, and the bacteria gets invited, and bacteria infects the wall. So you have to know that the organisms are all in our body. Some of them are in reserve, some of them are moving through the blood, and some of them are freshly infiltrated into our body. Now question, when there is gallbladder infection, you have to look for gallbladder wall and the gallbladder lumen. Gallbladder wall gets enlarged, gallbladder wall gets thickened. Normal gallbladder thickness, gallbladder wall thickness is in distended condition, it should not exceed 3 millimeter outer to outer. But if you measure the gallbladder wall in AP view, anteroposterior, then you will see the gallbladder wall is thicker, gallbladder wall is edematous, gallbladder wall has hypercongestion with the blood vessels, and the pericholecystic fluid. Look at here, the pericholecystic fluid around it. Okay, and this is gallbladder wall thickening. Now you need to click the color, then you will see there is a hypervascularity. It feels like the fire ring around the gallbladder wall. So what are the feature I just said to you? You will see the gallbladder wall thickness greater than 3 millimeter, presence of stone in the gallbladder, gallbladder wall is edematous and hypervascular, and pericholecystic fluid. Now I like to give you another idea that sometimes there is a single stone, sometimes there are multiple stones. So gallbladder will get infected. When the gallbladder get infected, sometimes you will see the stone in the neck of the gallbladder, it compresses the gallbladder wall, and the gallbladder vein gets compressed, then followed by arterial occlusion. So as a result, the gallbladder wall gets gangrenous changes. That is very dangerous. When there will be gangrenous changes in the gallbladder wall, so anytime gallbladder can be ruptured. Keep that in mind. At that time, gallbladder will be distended. We call it gallbladder hydrops. And hydrops gallbladder, when the diameter you measure inner to inner, only the anechoic area. So example, if you want to measure here, measure from here to there. If it is 5 centimeter or greater than 5 centimeter, we call it hydrops gallbladder. So make sure you noticed it. Otherwise, gallbladder can be burst. And you know that if the gallbladder is burst, so then what gonna happen? Gallbladder contains bile. Bile is a chemical materials. So that will cause intraperitoneal infection, generalized infection. We call it general peritonitis. Our body will try to conceal the bile, but it is not always possible. And in gangrenous condition, you will see there will be lot of cellular debris inside the gallbladder wall. So understand that this is the cross section, transverse view. So gallbladder wall is thickened. Okay, here multiple stones I see. Look at here, there is a posterior shadow is there, but it is not unlikely that you may not get the posterior shadow, because some of the stones in the gallbladder composition is different, so it may not have the posterior shadow. Here we see the posterior shadow here. So this is gallstone, multiple gallstone, and the wall is thickened, and there's a free fluid over here. Okay, and okay, this stone is this posterior shadow. It is the due to the stones. Okay, so this is all about the acute cholecystitis. Please do not forget this. And definitely blood work will be, so WBC count will be very high, WBC count. And in this condition, the Murphy sign is positive. Please, you need to know what is Murphy sign. Murphy sign is a clinical on bedside examination, and you can do the Murphy sign test, positive or negative, and those who are the examiner, they will do on physical examination and they will see the Murphy sign is positive. So now this is acute pancreatitis. This is a fantastic image, I will tell you. And look the pancreas here, the gorgeous pancreas. And we really, in normal condition, we don't see this gorgeous pancreas. It is so enlarged, and I will see this is diffuse pancreatitis. Why? Because the head, neck, body, tail, everything is swollen and echogenic. And you look, I see the common bile duct is here, is dilated, is due to anything obstruction, okay? And there should be one hole over here due to that is called gastroduodenal artery, the GDA. The gastroduodenal artery is supposed to seen over here, maybe this one too. Okay, so now look at here, the head. This is uncinate process. The head is going this. Look at pancreas is an unencapsulated organ. That means pancreas is naked. It has no capsule around it. That's why the clear boundary of the pancreas is unusually not very seen. And also you need to remember the duodenum is here. It obscured the head. The ligamentum teres is here. It obscured the neck. The pylorus is here. It obstructs the body, and the stomach is here. So it obstructs the tail. So that's why in normally we don't see very clean pancreas unless the patient is impure. Okay, so now this is aorta, this is IVC. Look at here relationship. IVC is just posterior to the head of the pancreas. So the head, if the head is enlarged due to any reason, it will push the IVC posteriorly. Okay, that is a board test question. You need to know this. So this is portal confluence. Portal confluence is made by the splenic vein and the SMV, superior mesenteric vein. Superior mesenteric vein goes vertically and the splenic vein comes horizontally, and they unite here in front of the uncinate process, behind the neck of the pancreas, and medial to the head of the pancreas. So this is portal confluence. Okay, and this is splenic vein. Okay, and if you are lucky, you will see the SMA is here, superior mesenteric artery, and this is IVC. If you are lucky, then you can see the left renal vein between the aorta, which is posterior, and the SMA, which is anterior to the left renal vein. That will give you the nutcracker sign, that is compression of the left renal vein due to the SMA anterior and the aorta posterior. So we have to measure the head. You're going to measure the head from here to diagonally this, then neck from here to this, then body you're going to measure from here to this, and tail from here diagonally like this. So if you are an experienced sonographer, so without measurement you can say, okay, now I see the pancreas is very engorged, pancreas is very enlarged, I see. So this is acute pancreatitis, and you're going to take the history from the patient. Patient will give you the history of acute pancreatitis. Most commonly, if it is pain in the epigastrium, and patient is having vomiting, nausea, pain is going through to the back, and pain is aggravating with the consumption of the alcohol. And another way you can also see that most of the time acute pancreatitis is due to the stone in the gallbladder, stone in the common bile duct that obstruct the common duct at the ampulla vater or sphincter odi. So it can cause the acute pancreatitis. Okay, so now this is acute pancreatitis 2. Look at here, there are fluid collection here. Okay, this fluid collection we call it pseudo pancreatic cyst. So look, this gorgeous head, the IVC is compressed posteriorly, and I told you before there is no clean border because the pancreas is unencapsulated organ. So this is IVC here, this is aorta, so this should be portal confluence, and this is splenic vein, and these are the fluid collection. Okay, so you can see we call it pseudo pancreatic cyst. Okay, so now this is, do I need to click the color? Yes, you need to click the color. What do you want to see? If it is an acute pancreatitis, you will see hypervascularity of the pancreas, and you know the pancreas is highly vascular organ. Okay, another day we will discuss about that anatomy, vascular anatomy of the pancreas. So now here there is a acute pancreatitis 2. So pancreas is gorgeous, pancreas is hyper, here it looks little hyperechoic. Okay, and here the pancreas is supposed to be more brighter, but when there is a acute pancreatitis, it is more edematous, no more congestion. That's why it looks like a same echogenicity as liver. Okay, so this is pancreas, and these couple of debris over here I see, and here fluid collection. Okay, so this is acute pancreatitis. Make sure your findings must correlate with the patient's history, and patient history and your physical examination. Then you will be the best sonographer. Next. Okay, acute appendicitis. Acute appendicitis, so in sagittal view and in transverse view. Let me look at that first. Here I like to show you a video clip that usually we don't see the appendix. Usually we don't see normal appendix, we don't see because it is small. The central lumen is not greater than more than 5 millimeter. Okay, and it is most of the time collapsed, and we don't see. But if you see a tubular structure in the right iliac fossa, and patient gives the history of pain, WBC count, pain in the right iliac fossa, and WBC count is very high, patient has nausea, vomiting, and the typical history of acute appendicitis, pain starts in and around the umbilicus, and then pain migrates to the right iliac fossa, and then you will see rebound tenderness is positive, and lot of times you will see the acute appendicitis is diagnosed on the bedside. Okay, when there was no ultrasound, so then usually the expert surgeon diagnosed the acute pancreatitis on bedside, clinical knowledge and their physical examination diagnosed. Here in this view you see the internal echo, that means there are a lot of debris inside, and here you can see the echogenic hyperechoic materials